Good morning, good afternoon, wherever you're joining us today in this first session of the IEB Day session. We're going to have a lot of discussions throughout the day, and we urge you all not to go away and stay with us. The first session that you have just joined is making epilepsy a national health priority. My name, as the co-chair of this session, I'm Amos, and I'm the Vice President of the International Bureau of Epilepsy in Africa. Mary, you can introduce yourself.
And thank you, Action. And as co-chair, I am Mary Secco. I'm the Secretary General for the IBE, at least until tomorrow. So it's been a beautiful 4-year term. And I'm also involved in global advocacy.
Okay, thank you, Mary, and I'm glad to be with you here. So as I've already highlighted today, the first session is on intersectoral collaboration, making epilepsy a national health priority. The objectives of this session is to consider the importance of intersectoral approaches to address issues that concern epilepsy, and also to create a platform of exchanging of ideas between our panelists and all that are in the audience about intersectoral collaboration. So we're looking forward to your comments. Just before I introduce the first speaker, just some housekeeping issues that we want to alert you to. We are going to have the first 2 speakers present, and after they do present, I will open it up for question and answer. So we have a Q&A box, if you look at your computer, which you can use so that we can receive your questions, pass them. The speakers are also having access to those questions. So we urge you to send in your questions through the Q&A. We will not be taking any live questions. And as you have noted, as you were logging in, this entire session is being recorded. So we thank you for your patronage and looking forward to some fruitful discussions. Just to have a kickstart without much ado, I would want to introduce our first speaker, and this is Dr. Tarun Dua, who is working as the head of the Brain Health Unit at WHO headquarters in Geneva, leading the work on brain health and neurological disorders across the lifespan in the organization, and coordinating the work in the areas such as epilepsy, dementia, and other neurological disorders such as neurodevelopmental orders and also Parkinson's disease. Her title for the presentation title, it's a 10-year Intersectoral Global Action Plan on Epilepsy and Other Neurological Disorders. Welcome, Tarun.
Sorry, I'm going to ask Anne and Elizabeth just to restart Tarun's video because we don't have any sound.
Hi, greetings from the World Health Organization. My name is Tarun Dua, and I work with the Brain Health Unit in the Department of Mental Health and Substance Use. I would be presenting the Intersectoral Global Action Plan on Epilepsy and Other Neurological Disorders. Let me start with the global context of neurological disorders. They are the leading cause of disability-adjusted life years and second leading cause of death. They cause 9 million deaths per year. And if you look at the contributors to neurological DALYs in 2016, the top 5 ones are stroke, migraine, dementia, meningitis, epilepsy. They are common all over the world. And if you look at the burden, more than 75% of the burden is in low and middle income countries. While at one hand, we have high burden due to neurological disorders, on the other hand, the resources are limited and the treatment gap is very high. And this is especially seen in low and middle income countries. So for example, only 1 in 10 people with dementia receive a diagnosis in low and middle income countries. Only 1 in 4 people with epilepsy receive treatment in low income countries. Same is true about access to essential medicines for other conditions such as stroke or Parkinson's disease. There is also shortage of workforce, and the distribution of the neurological workforce is uneven. So if there are 7 neurologists in high-income countries, it's only 1 per billion in low-income countries. In addition to these supply-side barriers, there are demand-side challenges, such as lack of knowledge, stigmatization, and discrimination, which hinders presentation to the healthcare facilities for initial or follow-up assessments and adherence to medications. In order to address the burden and the resource gap, the World Health Assembly in 2020 requested WHO to develop the 10-year Intersectoral Global Action Plan on Epilepsy and Other Neurological Disorders and submit to the 150th Executive Board. So what is the process of developing this action plan? The Secretariat first developed a discussion paper. The discussion paper was made available online, as well as virtual consultations were held with member states, UN agencies, and non-state actors, including civil society, academic institutions, and private sector organizations. Let me take this opportunity to thank IBE for submitting their feedback to the discussion paper. Following the comments that we received, the first draft has been developed, and it is now available for consultation. You can find it on our website, and we are also holding virtual consultations, again with member states and non-state actors. And it also includes patients and their families. Once all the comments are received in the month of August, we would be publishing these comments on our website. And based on the feedback that we will receive on the first draft, the revised draft will be submitted for consideration by the 150th session of the Executive Board, as well as we will have then it provided to the World Health Assembly in May 2022. A brief overview of the first draft. Let me start with the scope. We already discussed that the scope in terms of including neurological disorders, it's broad. And these are the conditions that affect the central and peripheral nervous system. It looks at neurological conditions in relation to the functioning impact and the disability impact. It takes an integrated person-centered framework, and this includes prevention, treatment, care, and rehabilitation. It builds on and enforces strategic interlinkages with other relevant public health disciplines and global commitments, such as for mental health, non-communicable diseases, the ones that are related to maternal and child health, and many others. The vision of the action plan is a world in which brain health is valued, promoted, and protected. Neurological disorders are prevented and treated. Mortality and morbidity are avoided, and the quality of life of people with neurological disorders and their carers is improved. and that people affected by neurological disorders fulfill their potential with equal rights, opportunities, respect, and autonomy. Thus, the goal is to reduce the stigma, impact, and burden of neurological disorders, including associated mortality, morbidity, and disability, and to improve the quality of life. In order to achieve the above stated vision and goal, epilepsy prevention and treatment and care is to be leveraged as an entry point. And I'll go into the details as I describe the strategic objectives. There are 6 guiding principles underlying the action plan. First one being people-centered primary health care and universal health coverage. Integrated approach to care across the life course, as I mentioned earlier, that you see some of these disorders in childhood, while others in older adults, and epilepsy, which is common in both children and older adults, builds on evidence-based practices, intersectoral actions such as involving employment, education. Importantly, empowerment of persons with neurological disorders and respecting the principles of gender equity and human rights. There are 5 strategic objectives, and each of these strategic objectives has different action areas, and then there are targets and indicators. So the first strategic objectives is prioritization and governance, and it includes action areas on advocacy, policy plans and legislation, and financing. The second is on diagnosis and treatment and care, and it includes care pathways, for example, from community to specialist care, medicines, diagnostics, and other health products, such as access to essential medicines, health workers' capacity, training and support, including primary healthcare workforce, and support to carers. The third strategic objective is promotion and prevention, and this includes promotion of optimal brain development in children and adolescents, promoting healthy behavior across the life course, and this includes risk factors such as smoking, alcohol, infectious disease control. So, for example, neurocystic psychosis, which is related with epilepsy, preventing head spinal trauma, and reducing environmental risks. The fourth strategic objective is on research, innovation, and information systems. And so it is about building the research infrastructure, more financial investment in research. And the second action area is on data information systems, both at population level as well as routine health information systems level. The fifth strategic objective is about public health approach to epilepsy. It's about improving access to services for epilepsy, engagement of and support for people with epilepsy, and using epilepsy as an entry point for other neurological disorders. As I mentioned, each of these strategic objectives has its sets of targets and indicators. Do remember that when we talk about these targets, they are at global level, but we will encourage countries to develop national targets based on the global framework that the action plan will be providing. I won't go into the details of each of the targets and indicators, but as an example, and let me take the one on epilepsy, the strategic objective, which is about to strengthening the public health approach to epilepsy and promoting synergies with other neurological disorders. The target is about countries have increased service coverage for epilepsy by 20%, and this will be, the indicator is proportion of persons with epilepsy who are using services. So thank you very much for asking WHO to present the action plan. I take this opportunity to ask IBE and people who are listening, the participants of this conference, to submit their feedback through WHO website or sending us an email with their comments on the first draft. Thank you very much.
We want to thank you, Tarun, for that very informative presentation, where we have noted even the principles around the Global Action Plan. One of them is the intersectoral action and also people-centered, which is what we're discussing today. So thank you so much. Over to you, Mary.
Thank you. And again, thank you as well, Tarun. And we look forward to having a Q&A with you after our next speaker. So it's a pleasure for me to introduce our next speaker, who is Dr. Alla Guekht. Alla is both a medical doctor and a PhD. She's the director of the Moscow Research and Clinical Center for Neuropsychiatry, and she's a professor of neurology of the Russian National Research Medical University. She is the vice president of the ILAE, so the International League Against Epilepsy, and where she chairs the Global Advocacy Council, and she's the incoming ILAE treasurer. She also serves as the elected trustee of the World Federation of Neurology. And Alla is very, very productive. She also publishes in epidemiology, burden and stigma in epilepsy, as well as epilepsy after stroke and TBI. So welcome, Alla, and I look forward to hearing your talk.
Dear colleagues and friends, dear ladies and gentlemen, it's a great pleasure and honor to speak at this meeting, and many thanks for your kind invitation. I don't have anything to disclose. We were supposed to be in beautiful Paris, and I would like to quote Anatole France: "The future isn't present, but also in the past." We're discussing the role of IGAP in improvement of care for people with epilepsy. But importantly, the resolution and the action plan would have never been possible without the historic accomplishments in the last decades. Global campaign was indeed the beginning. The goal of the global campaign was to raise awareness, increase education, and improve service to reduce the treatment gap and bring epilepsy out of the shadows throughout the world. The global campaign against epilepsy was born owing to 4 outstanding persons: Professor Ted Reynolds, Ms. Hanneke de Boer, Dr. Leonid Prilipko, and Dr. Shishuli. The glorious history continued, and all the landmark events presented at this picture from the global report deserve special attention. It is impossible to address them in my short presentation, but I invite you to review this picture in the report and the infographic at the ILAE website. The resolution of the 68th World Health Assembly was a milestone of years of collaborative efforts among ILAE, IBE, WHO, and the member states. China initiated the resolution, Russia was the first to join, and eventually 93 countries co-sponsored the resolution, and 43 made strong statements in favor. The Global Report Against Epilepsy is the prominent document produced by the WHO and key partners. It highlights the evidence on the burden of epilepsy and promoted epilepsy as a public health imperative. The set of urgent and well-documented actions was developed, setting the stage for further landmark events and documents. In fact, even the preparation to the action plan already allowed to enhance attention to people with epilepsy and to make significant steps to improve care. It was the landmark resolution of the 73rd World Health Assembly that called for the action plan. It was co-sponsored by the Russian Federation, Belarus, Bhutan, China, Colombia, Eswatini, the European Union and its member states, Guyana, Iceland, Jamaica, the Philippines, and the USA. The resolution highlights that epilepsy is a highly treatable condition and that more than 70% of people with epilepsy could live seizure-free if they have access to appropriate treatments. The need to address existing gaps in prevention, care, treatment, and rehabilitation was underlined. The resolution further raised the profile of epilepsy as a public health imperative. In order to improve significantly care for people with epilepsy, we need the powerful action plan with a prominent position of epilepsy. Currently, it is being advocated by the member states and by the epilepsy community. Also, there is an excellent example of joint interventions of the member states and professional and patients' organizations demonstrated by the African region. Owing to the resolution, The item on epilepsy and other neurological disorders is included in the agenda of the regional WHO events. That is very important for the improvement of care in the WHO regions. The resolution also noted that epilepsy and other neurological disorders often coexist. The concept of epilepsy as the entry point is very much appreciated and important for leveraging IGAP in order to improve care for people with epilepsy. The epilepsy community sincerely appreciates the long-standing collaboration and outstanding support to the case of epilepsy from the global and regional neurological organizations. As stated in the joint letter with the World Federation of Neurology and International Child Neurology Association, a number of diagnostic and therapeutic technologies, as well as many preventable, pharmaceutical, psychological, and research approaches are shared by epilepsy and other neurological disorders. Epilepsy and neurological communities believe that by setting an ambitious, evidence-based cascade target, intersectoral actions will be enhanced. I will come back to this cascade target in a minute. And we are looking forward to future, hoping that IGAP will be very instrumental and important to improve care for people with epilepsy. Tarun gave a great overview of the first draft, so I may be brief. We would like to congratulate the WHO, personally Deborah Castell and Tarun Dua, and the Brain Health Unit for the excellent first draft with the Objective 5 focused on epilepsy. One of the major components of the Objective 5 is very much aligned with the need to overcome barriers acknowledged in the global report, to combat stigma and discrimination due to ignorance, misconception, and negative attitudes surrounding epilepsy. People with epilepsy often face serious difficulties in education, employment, and marriage. The action plan is a powerful instrument against it. The IGAP calls to develop and strengthen models of care for epilepsy, enhance training and support in epilepsy diagnosis and management, develop strategies to ensure prioritization of epilepsy in workforce planning, implement strategies to make anti-seizure medications more available, accessible, and affordable, improve care to prevent the common causes of epilepsy. There are very important components of the improvement of care for people with epilepsy. However, the success of the demonstration projects in China and other countries contributed to the understanding that even more ambitious goals are evidence-based and achievable. In fact, the resolution of the 73rd World Health Assembly requested to include in the Intersectoral Global Action Plan ambitious but achievable global targets in epilepsy and other neurological disorders, strengthening service coverage and access to essential medicines, improving surveillance and research, and addressing discrimination and stigma. This is very much in concordance with the cascade target proposed by the ILAE and IBE. 90% of all people with epilepsy are aware of their diagnosis as a treatable brain disorder. 80% of people diagnosed with epilepsy have access to appropriate, affordable, safe anti-seizure medicines. 70% of those treated achieve adequate seizure control. This target is evidence-based, and these actions are achievable and have been already achieved in real-life demonstration projects and international studies. The resolution and the draft of the action plan highlighted the ongoing need for research to improve prevention, early detection, treatment, care, and rehabilitation, including treatment options with the potential to cure epilepsy and other neurological disorders. As stated, people with epilepsy, their carriers, and organizations that represent them should be empowered and involved in advocacy, policy, planning, legislation, service provision, monitoring, and research in epilepsy. This is aligned with the ILAE strategic plan and projects of the Global Advocacy Council. Also, the action plan will empower the epilepsy community to promote research in epilepsy and to incorporate participatory action research methodology into large-scale studies. We are very much looking forward to the action plan, the first WHO action plan on epilepsy and other neurological disorders. We would like to thank again the WHO Secretariat for the draft. We greatly appreciate our long-standing collaboration. Many outstanding people contributed to each achievement over these 2 years of the excellent collaboration between the WHO, ILAE, and IBE, and are currently working diligently to improve care for people with epilepsy. Thanks a lot to everyone, and many thanks for your kind attention.
Thank you, Alla, for this great comprehensive talk that gives us both the past of how we got to the IGAP today and also some opportunity for us to envision a future with improved care in epilepsy. At this time, we'd ask that Tarun and Alla please unmute and show us your camera, because we'll take some questions from the audience. Actually, there were several questions in the chat box. And I'll begin with the first. The first speaker identified, so Tarun, that only 1 in 4 people with epilepsy in lower income countries receive treatment. She also identified that the 10-year goal is to see an improvement of 20%. This appears to leave many people behind. Is this goal too low? What are the barriers to increasing this goal? So we'd ask that of Tarun and also Alla afterwards. So just need your mic off. Thanks, Tarun.
Thank you very much, Mary. Can you hear me?
Yes.
Great. Now, thanks very much for raising this point. As we know that the targets are globally defined targets, and it requires the member states to review what ambition that they would like to see in such targets. And therefore, this comment from the civil society NGOs is especially important, that the feedback that we are getting, that we should be ambitious in our targets. So this point is very well noted, and we will take into consideration from the WHO Secretariat as the second draft of the action plan is developed. Thank you, Mary.
Terrific. Actually, did you want, thank you for that comprehensive answer. Alla, did you want to respond to that?
I would be happy to follow Tarun. May I just ask the organizers to allow me to switch on video, because I'm skipping messages that it's not possible for technical, because the organizers did not allow me.
Oh.
That's okay. Actually, it's more important that you hear me. Okay, good.
We can see you.
Thank you. That's okay. Well, thank you very much. And I would like to thank again the Secretariat of the WHO, Deborah, Tarun, and all the brain health team, because it's really a very good action plan. And the 5th objective is absolutely excellent. And there are a lot of ideal components that would be definitely beneficial for the care for people with epilepsy. But I mean, the 90-80-70 target, I think, is very much aligned with the goal of the resolution. And actually, it meets their request in the resolution to set achievable, global, and affordable targets. I would like to highlight very briefly that actually it's a smart target. It's specific, it's measurable, it's achievable, it's relevant, and it's time-bound. And within 10 years, it's absolutely feasible in collaboration with the WHO member states and ILAE, IBE, and actually all their organizations that are involved, all the partners, to achieve this goal. So also, indeed, if we just are looking at the global report, it's an excellent book. And once again, many thanks for the WHO to publishing it.
Indeed, we have examples of China, we have examples of Philippines, we have examples of other demonstration projects, and I'm just mindful of time. It's a very good confirmation that all these targets are available, and actually also the 80% target is very much in line with the WHO Global Plan for Prevention and Control for NCDs. So I think it's achievable, but it's a challenge, but hopefully together we will overcome all the challenges. Thank you very much.
Thank you for sharing that. And I think the whole topic today is intersectoral collaboration. And I don't think any of these goals in any of the 5 strategic areas are going to be achieved if we do this in silos. And I think it's so critically important to advocates on the line. So when I say advocates, all people with epilepsy who have joined today, that we need to share our voice. We need to tell our governments, our policymakers, our communities that this matters if we want to see change. And Action and his team in Africa have done an exemplary job of that. Action, I have another question here. I don't want to take over the stage, but the question I have is, how can we demonstrate the progress made in reducing stigma, improving knowledge, and generally improving the quality of life with epilepsy, for people with epilepsy and their families through these targets? Like, how will we be measuring some of these things? It's a tough question. So Tarun, I'm going to go back to you to answer that one.
Thank you, Mary. Thanks for giving me the opportunity to discuss a little bit more about the targets and indicators and how these works for a global action plan. So just to clarify, these targets are global targets based on what the globally across all the world that countries should be able to achieve. For example, if we have let's say, if we have a target that 50% of countries have a particular policy or a plan, let's say STAT, many of the high income countries may be starting with a policy or a plan, and they would feel that this is something which is not ambitious enough for such income, for such a country. But the idea is that globally, as a community across the 194 member states that we have, what should be the level of achievement or the ambition that we should be going for? So usually these targets are in terms, so looking at the total number of people or by the number of countries we have this information. One of the feedback that we always receive from the member states is the feasibility of measurement, what is the burden on the country's information systems for monitoring the number of indicators. So while we may think that there are absolutely, these are vital indicators, member states, they always tell the Secretariat to keep the number of indicators, the global indicators, minimum. And so therefore you would see that we may have, for example, each of our strategic objectives may have 3 action areas, but they may have 1 or 2 targets only, just because this is the request that we receive from member states. Having said that, the point that I wanted to come with this long story is that we encourage countries to have national targets and national indicators, and they need to be as detailed as possible because they give us the information on what is happening at the national level and what kind of services are being available. And this will be the place where the issues related to stigma, issues related to discrimination, issues related to awareness of the population, and the measures being taken can be kept. We have done this successfully in other areas. For example, in dementia, we have for a global dementia observatory. So while there are 7 global targets, the observatory has 35 targets and indicators, which help in the national monitoring. And that's, I think, what we will encourage countries to have, the national targets and indicators. Over.
Thank you. That actually helps a lot for us to know as civil society what we should be helping to monitor as well. We have another question. How can WHO activate national governments to help associations make epilepsy a priority?
Mary, you were cutting out a little bit, so can you please repeat the question?
Yes, so the question in the Q&A is, how can the WHO activate national governments to help associations make epilepsy a priority? And this came from Morocco.
Thank you. I think that's very important, and this very much links with the topic for discussion, which is about the intersectoral collaboration or multi-partner collaboration that we are talking about. If we have to address the huge burden that is due to epilepsy or any other neurological disorder, a viable partnership, an active collaboration and partnership between civil society and the Ministry of Health is extremely important. And in our opinion, we see this action plan actually as a catalyst for enhancing this partnership at country level. I think this, if having such a global target or indicators and strategic objectives and action areas that are relevant to epilepsy, where the actions are that the countries should be establishing these civil society organizations, or there should be support to such civil society organization, it provides us the opportunity to have that dialogue and the commitment to improve epilepsy care. So we see this as a paradigm shift that's going to happen in the coming years to help us improve epilepsy care and enhance the partnerships.
Well, thank you for reinforcing that, because that's our goal as well. It's to have the group that is on today and the whole IBE community, which is people with epilepsy, realize that their voice is vitally important and that they can make change in their own communities. So part of this session today, and as we move on to the next speaker, is to really talk about ways we can influence change. So thank you, Tarun and Alla, terrific jobs. We don't mind if you go and black out your cameras now, because we'll go on to the next session, and I'll ask Action to introduce our next speaker. Thank you.
Thank you all, and thank you for all the questions that we received. It has been overwhelming, and we're sure that to those that indicated their names, some answers will be provided to your questions. We're sorry for that. Now we moving on to the next speaker with in mind our motto of not leaving anyone behind. So now we are talking about children. So our next speaker is Professor Joe Wilmshurst. Is the head of pediatric neurology at the Red Cross War Memorial Children's Hospital, affiliated to the University of Cape Town in South Africa. She's part of a number of working groups for International League Against Epilepsy, and is the incoming chair for the African Commission, as well as the president for the International Child Neurology Association. She has a special interest in improving the care of children with epilepsy. She's a director of the African Pediatric Fellowship Program based at the University of Cape Town, and a training program which has trained some 150 pediatric clinicians in specialist areas from across Africa. And the title of her discussion with us, it's improving care for children with neurological disorders in resource-poor settings. Professor Joe, your time.
Thank you very much for the opportunity to present at this wonderful day, the IBE Day 2021. The topic I've been asked to talk about is improving care for children with neurological disorders in resource-poor settings. And this is on behalf of the International Child Neurology Association. These are my disclosures. So how do we attain universal health coverage for children in neurology practice? The reality is that our focus should be revolving around prevention, early recognition and intervention, diagnosis and chronic care. But for this to occur, we need to have adequate training and education of the people delivering that care. We can't do this without understanding the populations we're looking after and understanding if what we're doing is correct. So we need effective research, understanding the epidemiology of our populations, and audit of our practice. And only with this will we be equipped to be able to have effective advocacy and lobbying and addressing the terrible stigma that is affected by many people with epilepsy. So this is the reality. Our child is born into an environment that they are affected by the setting that they are born into. They are affected by the direct influences that happen to them as they grow up, by the available interventions, and by their overall genetic makeup. And overriding this are the challenges they face with ineffective preventative care, the burden of diseases in their area, the disparity between rural and urban healthcare, the challenges with public and private disparities, the huge stigma affecting many people with epilepsy, access to facilities, the sustainable supply of treatments, and over the problems with training across all levels of care. So just looking at prevention alone, this example here of a risk-benefit analysis that was performed related to the African continent identified that for one excess COVID death that occurred at the time of attending a routine vaccination clinic, 84 deaths in children could be prevented by sustaining that childhood immunization program. And as we know, there have been huge disruptions in routine vaccination programs worldwide. Maternal health is paramount. And this data here demonstrates the huge disparity across Africa and Southeast Asia for neonatal mortality compared to resource-equipped settings. And when we think about prevention, perinatal insults have the largest distributable etiology in children. And when we measure the various preventative causes from perinatal causes, CNS infections, traumatic brain injury, and stroke, 25% of epilepsies worldwide are preventable. Considering communicable disorders, bacterial meningitis remains a huge scourge worldwide, and a quarter of these patients will be affected with neurocognitive sequelae. Tuberculosis remains a huge issue and is of pandemic proportions in the area that I work in, South Africa and Sub-Saharan Africa. And the 1% that suffer TBM suffer devastating consequences. Again, emphasizing that with effective vaccination, we would be able to prevent many of these issues, and vaccine availability is very variable in low middle income settings. For other preventable causes, 1 in 4 children with cerebral malaria will suffer long-term cognitive impairment. Neuropsychosis, poor pig pen management practices and sanitation are huge issues, and in many low middle income settings, cysticercosis, where it's endemic, it is the leading cause of seizures. When we consider the magnitude of epilepsy, the prevalence in sub-Saharan Africa is twice that of other regions of the world, and as stated earlier, 1/3 of the pediatric cases are related to perinatal insults. And the treatment gap is a huge issue worldwide, but especially in low middle income settings, with figures as high as 73% in rural areas. And this is believed to be related to manpower, cost, cultural beliefs about epilepsy, and poor access to anti-seizure medication. An area which I feel has been undercovered in the report, and I hope the IGAP report will now emphasize this more, has been adolescence. And this document that was published through The Lancet highlighted that over 1/3 of adolescents are based in countries that are non-communicable disease predominant, where the major burdens on mental and substance use disorders and chronic ill health are paramount. Over 1/2 of adolescents live in multi-burden countries, and 1 in 8 adolescents live in injury excess countries. But the report stated that universal health coverage requires accessible packages of care that are matched to the local need and acceptable to adolescents and young adults. And that we must create opportunities to extend youth engagement in the real world. This requires financial investment, strong partnerships with adults, training and mentorship, and the creation of structures and processes that allow adolescent and young adults involvement in decision-making. What about available interventions for child health? Compounding factors in low middle income countries are that healthcare facilities and capacities cover many burdens. The distance to travel is often significant. There's lack of infrastructure, unreliable access to diagnostic tools, lack of subsequent treatments, and untenable costs for procedures. The site of care for many neurological conditions in low middle income countries, especially Africa, is psychiatric units, which further compounds the stigma associated with neurological disease. Considering future perspectives, clearly, as I've emphasized, primary prevention is paramount, with fairly cost-effective interventions such as immunization programs, avoidance of nutritional deficiencies such as iron deficiency, management of malnutrition, implementing insecticide-treated bed nets, implementing pig pens and road fences and seat belts. When we consider diagnosis in low middle income countries, this is often based to the most basic of tests. Neuroimaging is often unavailable. So we need affordable, easy to use rapid diagnostic assays that can be covered at the point of care to identify infections affecting the nervous system. We need simple algorithms that are guiding us for effective therapy or appropriate referral. I'm going to close with the last few slides addressing an area which is very much at the ethos of the ICNA and something that I feel very strongly about, and stealing this quote from Nelson Mandela. Education is the most powerful weapon which you can use to change the world. This is an example from a study in Africa where for a population of 927 million across 34 African countries, there were 148 clinicians who were based in care for child neurology. They weren't necessarily specialists, but they were the key providers. So it's not surprising you have this anorexic map for Africa delivering healthcare. But the reality is it's not just about the doctors. We have to work in teams. We need hubs of expertise. We need to be recruiting people experienced in nursing and rehabilitation and technologists, to name a few, to work together. So how can we close and try and pull this together? Clearly, preventative interventions will significantly impact on the burden of child health. The pathway to this is to ensure equipped healthcare professionals who can advocate, lead, and train in the local setting to support high-level care across all levels of healthcare and establish effective systems. To target areas to enable universal healthcare, we need early intervention, to close the diagnostic and treatment gap, to establish accessible diagnostic tools, to ensure sustainable and cost-effective treatments, and to promote chronic care packages. Thank you. I would like to acknowledge my colleagues in the EPNS, ACNA, OCANA, and CNS of the other child neurology societies who have all been engaged with and supported these comments. Thank you.
Thank you, Joe, for an excellent talk. And I hope you'll be available to answer questions at the end. We're going to go through a couple more speakers first. So I encourage people to put your questions in the Q&A box for all of the speakers. Our next speaker is Gaby Ooms. Gaby is a health scientist with a specialization in global health. Gaby has been involved in Health Action International's research project since 2016, when she researched access to internationally controlled essential medicines in Uganda. So from 2017 onwards, Gaby has managed research across Health Action International's projects on sexual and reproductive health, snakebite, ICEMs, and artificial intelligence. And in 2019, she began her PhD at Utrecht Center for Pharmaceutical Policy and Regulation. So Gaby will help us to understand more about access to internationally controlled essential medicines in lower and middle income countries. Welcome, Gaby.
Hi everyone, and thank you for the opportunity to present at this conference. Just to introduce myself, I'm Gaby Ooms, a research manager at Health Action International. So HAI is an NGO working on improving access to essential medicines through research and advocacy, which is aimed at advancing policies that enable access for everyone everywhere. So in HAI, we work on specific projects with this goal in mind. And these include projects on European medicines policy, one on improving access to insulin, another one on sexual and reproductive health commodities, as well as a project on snakebite prevention and treatment, and one that is a generic pharmacy chain modeling project. We are also starting one on internationally controlled essential medicines, which is what I'll be talking about during this presentation. So I think most of you might already know a little bit about controlled medicines and how it's regulated, but I'll just quickly give some background on them. So controlled medicines are essential because they are listed on the WHO model list of essential medicines, and they're controlled because they are listed on one of the 3 international drug control conventions. So that's the United Nations Single Convention on Narcotic Drugs, the United Nations Convention on Psychotropic Substances, and the United Nations Convention against the illicit traffic in narcotic drugs and psychotropic substances. So these conventions include substances which have no proven therapeutic value, like heroin and cocaine, but also includes critically important medicines which are essential for the health and well-being of people, and hence their listing on the WHO essential medicine list. So there are 14 medicines that are both essential and controlled, and they are used for anesthesia, epilepsy, harm reduction, mental health, obstetrics, and pain and palliative care. This table is an overview of the 13 relevant medicines, and you will recognize diazepam, lorazepam, midazolam, and phenobarbital. So why are they listed on these conventions if they're essential? Well, that's because they are potential for misuse or abuse. Think, for example, of the opioid crisis in the global north. So because of this potential for abuse, controlled medicines are subject to extra regulations. And so why is it relevant to know more about these medicines? It's because they affect millions of people, especially those living in low and middle income countries. So, for example, 5 billion people have no access to surgical care or anesthesia care. 5.5 billion people would have no or low access to opioids if they were in need of them. And 25 million people living with epilepsy, for example, receive no treatment. This is, I think, really demonstrates the disparity in access. So about 92% of morphine used worldwide is consumed by only 17% of the population, all of whom are living in high-income countries. Another example is that the US, for example, has 150% of the morphine available to cover what their population actually needs, compared to Nigeria, which only has 0.2% of the morphine available to cover what their population's actual needs are. This slide shows the proportion of the population without access to surgery. And the darker the red, the less access that the people have. And again, you can see that it is especially Africa and Asia that are affected. This slide is similar. This figure shows the availability of opioid substitution therapy, which is a treatment for those who are suffering from addiction. And red shows that this therapy is available in the community, with black showing that it's available in the community as well as in prisons. While the light gray is showing there's no opioid substitution therapy available at all. Again, this is mostly affecting countries in Africa, Asia, and Latin America. So I think these figures and numbers have shown you what the burden is across the world. And we can now take a closer look at what the barriers are that are causing this very limited access to these medicines for so many people. So the key cause of the barriers to accessing controlled medicines is the listing on one of the conventions. And because they are listed on these conventions, countries have to estimate the needs for these controlled medicines for their population. However, you can imagine that in low and middle income countries where health systems are often weak and they often do not have systems set up to estimate their population's needs, this is very difficult. So what you saw on the slide of the unmet needs for opioids can, for example, for a large proportion also be explained by this, that it's just very difficult for the countries to actually estimate their needs because they have no idea about it. On top of that, because controlled medicines are listed on these conventions, they are also subject to extra regulations, which are often excessively strict. So, for example, limits may be set on dosages or maximum number of days for which a controlled medicine can be prescribed, or healthcare professionals require a special license to prescribe or dispense these medicines. So it's not surprising that this affects the availability as well as the affordability. The overly restrictive regulations limited the size, for example, of the market for manufacturers, which can pull up the costs. What is also often seen is that in low and middle income countries, the costs are much higher than in high income countries. This also has to do with the market share. So, for example, in Portugal, a 30-day treatment with morphine is available for less than $10, while in Panama, the same treatment costs almost $380. So that's a really big difference. Then there's also some barriers on the service delivery side. Namely, healthcare workers often lack the knowledge how to handle and dispense controlled medicines. On top of that, there's also a chronic shortage of specialists, such as doctors who can prescribe opioids, anesthesiologists, and also neurologists. A lack of proper training and education also affects healthcare workers' their beliefs. Prescribers are, for example, often reluctant to prescribe controlled medicines due to the stigma surrounding the medicines and the belief that the use will lead to dependency, but also because of the strict regulations. Sometimes they are also afraid to prescribe these medicines because they are afraid to get in trouble if something goes wrong with the prescription, the different forms that they have. Which sometimes can lead to healthcare workers losing their license. Another barrier is also that the perceptions of the population in general about controlled medicines. And these perceptions exist among the general population, but also among healthcare workers. So in many countries, controlled medicines are categorized as dangerous or poisonous, which results in a fear for their use. And also the fear that the use will lead to misuse. And amongst patients, there's also the fear of a reduced quality of life and side effects also. And then there's, of course, I already shortly mentioned it, the opioid crisis in the global north. And this is a textbook example of how irrational and excessive access to controlled medicines in interaction with like the complex socioeconomic and cultural circumstances have gone wrong and have led to this overconsumption and misuse of opioids. And this also underscores why regulation is important and that a balance needs to be found between preventing abuse, but also ensuring access to these controlled medicines for those in need. So the opioid crisis has also affected the narrative about controlled medicines and also their potential for abuse. And this consequently also affects the access in low and middle income countries. Here are a few examples of the situation in specific countries. So, for example, availability of phenobarbital in Laos only meets the needs of less than 2% of the people living with epilepsy. Here are a few examples on access to morphine or the availability of morphine. And in Ghana, for example, physicians are allowed to prescribe opioids to a patient in doses limited to 2 days. And you can imagine that for many people, it would be very difficult to go to the doctor every 2 days to get that doses, which therefore also becomes a significant access barrier. So now that there's a bit of a background about controlled medicines and the similarities in barriers that people might experience accessing controlled medicines, I'm going to tell you a bit more about a meeting that I organized. It was a 3-day meeting, and we experts from 5 different care fields, as well as drug policy experts, attended this meeting. And the aim of the meeting was to explore access issues across the care fields, to see what the commonalities and differences in barriers are, and also to see whether these experts saw added value in collaboration across the care fields to improve access. And lastly, we also saw it as a networking and mutual learning opportunity for everyone who attended, if nothing else. So during the meeting, the participants recognized the shared barriers to access, and mostly those that I listed a few slides back, and agreed that many are control related, that they're also context and country specific, and that most of the care fields are marginalized, which is also a barrier in itself as well. So they agreed upon that they saw the value of a coordinated approach to improve access, and would actually like to work together on this effort. So next steps would be to further define how such a collaborative approach would look like, probably consisting of advocacy, both internationally, but also at the country level, as different countries have different regulation in place as well. And also how to utilize this together to improve access to controlled medicines. We believe that this would be an interesting opportunity which could be explored for further, as maybe working together across the care fields would make for a strong case to try to improve access for rational use of controlled medicines. Yeah, let me know if there's any questions. Feel free to ask. Thank you.
We want to thank you, Gaby, for that presentation where we saw the value of coordination as well as collaboration. We really thank you for that presentation, and we'll talk to you later during the question and answer session. And we urge all participants, those in the audience, please keep pushing your questions through the Q&A tab. Now we are moving on, and the next speaker is Gardiner Lapham. Gardiner Lapham has a background in nursing. Sorry, just a moment. Gardiner Lapham has a background in nursing and international public health, and is a passionate epilepsy advocate. After losing a son to sudden unexpected death in epilepsy, Gardiner got involved in a number of efforts to promote research, awareness of this tragic phenomenon. She is currently leading an effort in the US called Partners Against Mortality in Epilepsy. Gardiner also cares deeply about narrowing the epilepsy treatment gap, especially in Africa. Through the BAND Foundation, of which Gardiner is a trustee, she supports community and primary care level interventions in Africa that increase access to epilepsy care. She has partnered with the International Bureau of Epilepsy on the advocacy project called Making Epilepsy a Health Priority in African countries. And the project currently is running in almost about 8 countries. And the topic of your discussion is working with donors. Gardiner, it's your time.
Hi, my name's Gardiner Lapham. I'm with the BAND Foundation, and I'm really thrilled to be here. I want to thank the IBE organizers for including me. They've asked me to speak on a donor's perspective to narrowing the treatment gap. So first, I'm going to walk you through sort of how and why I got engaged in this issue, and also then to share some thoughts on how we might be able to pull more donors into this space, which is badly needed. So let's see here. I wanted to first start with why I was so compelled to get involved. First and foremost, epilepsy is a deeply personal issue to me. I lost my 4-year-old son to sudden unexpected death in epilepsy, SUDEP. About 13 years ago, Henry had only just been diagnosed with epilepsy before he succumbed to SUDEP. So it was devastating and shocking, and I didn't know what to do. I eventually found my way to an epilepsy organization in the United States where we live, and started to get involved with that organization, and started to meet a lot of other people who had lost children to epilepsy. So the issue became a big part of my life. How do I get involved to advance research, promote understanding, and drive prevention? So I worked in the US for a number of years, which I continue to do. But in the past, I guess the past 5 years or so, I've become really interested and engaged in the global epilepsy treatment gap. Honestly, my background is actually in international public health, but when I first fell into these issues, I had no idea of the huge impact that global health epilepsy was having, or I should say the burden and the toll it was taking on individuals. I was really shocked to learn about the unacceptable treatment gap. But then on the flip, I saw it as such a huge opportunity to get involved because of the affordability around drugs and sort of the public health approach that can be taken to tackle this. So when I started to get engaged, I also began to learn about what was happening at the global level with WHO resolution. And that further encouraged me to learn more, because it felt like a really good time to get involved, because a lot was going on at the global level. So I asked, our foundation to get involved and to develop some strategic priorities. I met with leaders of IBE. I talked with a lot of other physicians who had worked internationally, as well as just other colleagues in global health, and developed some sort of strategic areas that our foundation was interested in pursuing and supporting. And the first one was really on systems change. I was really interested in how do we work with ministries of health to hold them accountable to the WHO resolutions, knowing that at the end of the day, we have to get greater buy-in to this issue for change to last. Another area of interest of ours was in supporting community-based organizations and working through community-based organizations and the people with epilepsy who drive those organizations. We just have always supported smaller organizations and believe that there is a lot of power and change that advocates can affect. And then the third area was really wanting to work in partnership, knowing that this is nothing that we could do alone, especially from the US, and that there were a number of great partners who were working at the community level who we could engage with. So I wanted to share a few projects that we have worked in partnership with. And that this one is with the International Bureau for Epilepsy. This was the first project the BAND Foundation got involved in. And this one was really exciting. We launched it as a pilot project because we really wanted to learn how to do this work. So the goal was we wanted to leverage the WHO resolutions and hold governments accountable. And we wanted to see how the IBE chapter organizations in Africa could do this work, and we wanted to listen to them and partner with them and hear what they needed to be more effective in this change. So two areas emerged, and one was there was an express need to build capacity around advocacy skills. So I'll get to that in a second. But the other area was that they needed funding to do this work. And so we launched a small grants fund to advance some advocacy projects as well as some, awareness projects. So one of the outcomes of this work was we built an advocacy toolkit. And we had a number of chapters in Africa contribute to the development of this toolkit, to share case studies. And then there was a training a few months ago to equip advocates with the skills they need to develop advocacy plans. So this toolkit can actually be found online. And I think there's going to be another presentation in this session going into more detail about this toolkit. But some of the lessons, I have learned in working with IBE is that you really need to listen to the community and the community needs. I think that's fundamental, and I hope that that is what's driven the BAND Foundation's partnership with IBE. What's been made the partnership successful is that there's been really good communication between me and IBE, the headquarters IBE, but then also the chapters on the ground and our lead project manager on the ground. And there's been great intersectoral collaboration, which has really, I think, made this project successful, bringing in lots of different experts from outside of epilepsy to help drive this work. We brought in lawyers and other healthcare experts and people outside of IBE. We've brought in people from the disabilities area. So it's really been a robust effort. And then perhaps a more specific area that a lesson that's been learned is the chapters that have been successful in getting the small grant awards have had really good grants. So we had created a process where they could submit rough drafts of their grants and have those edited by other professionals. And so that really helped improve the process and the quality of the program design. So one more project that was not with IBE initially, but has now sprouted a really nice partnership with IBE is a project that has been in partnership with AMREF Health Africa. And AMREF, as many of you might know, is a African-based large health NGO that works on all sorts of issues. Epilepsy really had not been on their radar until they've been working in South Sudan for a long time, and the issue of nodding syndrome became quite apparent up there. The onchocerciasis associated epilepsy has a huge impact in areas of Southern Sudan. So AMREF decided they wanted to get involved in epilepsy treatment and nodding syndrome prevention. So I saw this as a really great opportunity to engage a health organization to take on epilepsy, and they've done a great work training up different levels of providers in the primary healthcare system to refer and diagnose and treat patients with epilepsy. So I highly encourage this approach of finding partners outside of the epilepsy space who are already working on healthcare and who have the capacity to integrate epilepsy training into their programs. So those are some of my experiences, and my thoughts on working with donors are, first and foremost, we need to do a better job of telling the story. It is so rich what I have learned about how epilepsy plays out in Africa and what those challenges are. They are very different than the challenges in the US. And I think that there are so many stories that can be told and shared that could ignite passion and interest in places like the US, where some of these global foundations are located. So, so I think we need to tell the story, but not only tell the story. What is so compelling about epilepsy is that it can be affordably treated. And so we need to rally these donors who are interested in global health around this issue, because there's a lot of low-hanging fruit in addressing epilepsy. I also think that we need to get to donors and say, hey, you're funding this healthcare work. Why not also integrate epilepsy into your primary healthcare work? Like, epilepsy is a component that can be added on. There is evidence that demonstrates how it can be treated at the primary care level. So I think there's a lot of opportunity for donors to collaborate on this issue. And as always, think of your prospective donor as a partner and build your relationships. The point on developing well-written grants is, I think, very true. And then communicate often. I mean, I think donors really, really want to know what's going on and how to make an impact. And as hard as this past year and a half has been on all of us, it has taught us, that Zoom really can keep us connected in ways we never thought was possible. So I would encourage a lot of communication. And if anyone wants to reach out to me separately to talk about any of these areas, I would be more than happy to discuss further. You can find me through IBE. And anyway, thank you very much for having me be part of this presentation.
Thank you, Gardiner. It has been such a pleasure to work with you on trying to improve care in Africa. And everything you said, I hope all the audience noted around telling the story, because it really is impactful. But the most important piece for us is that you've looked at solutions and trying to pilot projects that make change. And that's so vitally important, because we have such an enormous treatment gap in the countries that you are prioritizing. So thank you. And we look forward to having people ask you questions at the end. Our next speaker is Karen Robinson. Now, Karen has been a registered social worker for 24 years and has worked in the corporate sector, the tertiary institutions, and in government. But Lucky Epilepsy, for the past 12 years, she's also worked at Epilepsy South Africa. So our next speaker, Karen Robinson, will talk about the Epilepsy Advocates Toolkit that was co-developed with IBE and BAND Foundation that was just mentioned a minute ago by Gardiner. So welcome, Karen.
Greetings from South Africa. I'm Tarun Dua. I'm a social worker by profession, and I'm working currently at Epilepsy South Africa, the Western Cape branch in Cape Town in South Africa. I'm quite excited to be talking today at the IBE Day at the 34th International Epilepsy Congress. I also feel very privileged to talk about a topic that's very dear to my heart, which is advocacy. And also, I was part of a team that trained the IBE Africa chapters in March and April. And today, I just want to share my experiences, because what we did was basically using the Advocates Toolkit as a basis for the training that you did in March and April. So let's just move to the next slide, just to give you an overview. So like I said, I'm focusing on the Advocates Toolkit, and just the outline of the session is to give you an introduction about the toolkit, how it was developed, just the overview of the modules, then just feedback also just from the training participants that we did training on in March and April, and then just closure. And the next slide. So the Advocates Toolkit really provides a guidance. It gives ideas. It inspires when working with advocacy projects. When that was, I think the aim for it was that it was aimed for civil organizations across Africa. There's different modules which we will briefly speak about shortly in the guide that will assist you to basically plan your advocacy process. The toolkit is very versatile and you can use it with different target groups. So then what also excites me about the process that was followed when developing the toolkit was that a lot of people were consulted, like input from stakeholders. Very important, input from people or a person with epilepsy and those affected, the IBE chapters across Africa, and also the headquarters representatives. The other thing that's also very important, even when you do whatever advocacy work for epilepsy, is that you need to do a needs assessment. You need to do collaboration between other stakeholders or like-minded people, and definitely with the toolkit, it's clear that that process was followed. So if we look at just an overview of the modules that is within the toolkit, there's 4 modules, and then there's another section, the last section, that focuses on tools and resources. So module 1 is the big picture, 2, planning your advocacy, 3, taking action, and then 4, expanding your reach. So what I will be doing, I'll just talk you through briefly what each module actually contains. So the module 1, the big picture, it's basically information on epilepsy and advocacy. And I think this is very important because when you do advocacy work, you need to contextualize. You need to contextualize it from an international point of view, then bring it closer to where you are in your country. So it focuses on epilepsy in Africa, so it gives key facts like what is epilepsy, who has epilepsy, is it treatable, or is it a disease, is it a condition, and then also what impact epilepsy has, and giving guidelines to what your key messages should be or what actions you should be taking when drawing up your advocacy plan. And it is linked, the messages, the overarching messages that guide your actions is also linked to the World Health Organization, which is very important. Then module 2, planning your advocacy. That module for me has a lot of practical tools in it. And the planning part is the hardest and it's very time consuming. So what I like about this module, that it gives you an understanding of what problems will people with epilepsy face in your community. It also provides many tools where you can assess your specific situation, and there's tools like very practical to you tools, and again emphasizing the fact that you need to speak to people with epilepsy to find out what are their needs, what are their problems. There's there's the problem tree. Another planning tool is the 5 whys. So really excited tools, which you will also find by the tools and resources section. There's also a template for that as well that you can use when you do it with, when you're busy doing your advocacy plan. Then in that module also, it helps you to define your goals and also SMART objectives for addressing the situation. And lastly, which is the most important thing, you then develop an advocacy plan to bring about change. Module 3, take action. That module focuses on different ways to advocate for change, whether it's by building community organizations, whether it's awareness raising, whether it's mobilizing, whether it's campaigning, whether it's a call for policy change. It also focuses on, activities that is very important also, that you need to decide on what activities are you going to undertake to implement your advocacy plan, which will obviously, it depends on your target audience and also your goals that you have for your advocacy plan. So would it be working with government and in understanding how that works, or would it be working with the media or community, or all 3 of them, involving all 3 of them? with your advocacy plan. Then module 4, expanding your reach, I think for me is also, well, all the modules is important, but it focuses on basically working in partnerships to ensure that you advocate for change. And obviously by doing that, you're increasing your reach and also your impact. So it speaks about different, looking at other organizations or government that you can partner with. And then also it covers international instruments. That is also important for you to know when working or when developing your advocacy plan. So that's in a nutshell the 4 modules. The last section, which is tools and resources, it's also very helpful because it explains, there's a glossary, there's all the tool templates, all the activities that's in the toolkit, there's a blank template there. And then the last one, the Annexure 3, has got the advocacy plan. So if you want to, it even guides you when you have a meeting with colleagues at work to discuss with them your advocacy plan, what process to follow, there's an agenda. So yet again, very practical, very user-friendly. And then lastly, what I wanted to say also, we also had a session in our, when we did a training where a South African attorney was also involved, and just sharing also, you know, the legal capacity for litigation around the African chapters and basically just mapping the laws that's impacting on people with epilepsy and how to deal with that across African countries and also specifically South Africa. So that was quite interesting as well, the legal aspect that was incorporated in that. And then this is just feedback that from the training that was done with the participants in March and April on the advocacy toolkit. So if you can see just the comments that they wrote about the training, and really from my side also very user-friendly, very practical, and it can help you to really draw up your plan. And like I said, you can do it with, you can use this toolkit to work with different audiences. And then lastly, I just want to like to end off with this quote, that education is the most powerful weapon which you can use to change the world. And I think the toolkit for me is one of those powerful weapons at this stage, because we all know a lot of people with epilepsy, the challenges they are facing, and we need to empower them to advocate for themselves. Thank you.
We want to thank you, Karen, for that presentation. What a good tool that has been developed and that is now currently being used by some epilepsy organization and some non-epilepsy organization. We thank you so much. Now we move on from one Karen in South Africa to another Karen in California. And this is Professor Karen Paco. Dr. Karen Paco is a professor of neurology at the University of California, San Francisco. She's a retired commissioner officer from the United States Public Health Service. Dr. Paco's career focus has been on improving epilepsy care on disadvantaged populations by building sustainable local systems of care. Together with Mary Spasiak, she leads the Global Health Task Force of the International League Against Epilepsy and International League Against Epilepsy Global Advocacy Council. The topic of discussion is Global Health in Epilepsy Database. Dr. Karen.
Hello, my name is Karen Parco. Thank you, Mary in Action, for asking me to speak. And thank all of you for staying with me here until the end of this session to hear about this database I'm going to tell you about. I'm going to tell you about a web-based repository of global health projects that I believe will help us all in our endeavor to collaborate internationally and improve care for persons with epilepsy. Here's the promotional material that you may have seen about the database. I'm going to spend the next few minutes telling you more about it. The database was created after recognizing that more and more regions were undertaking epilepsy global health projects in resource-poor countries, but often they did not know what projects had already been done or where they were being done. There was not a central resource, and often collaboration depended on word of mouth. We set out to create an electronic web-based repository or database that would list all ongoing projects and serve as a single place where all projects could be listed. Since ILAE and IBE together are the premier international organizations for epilepsy, we felt that this was the most appropriate home for the database. Our plan was to introduce this database to all regions at this meeting. We, probably like you, were hopeful that we would all be together in Paris, eating chocolate croissants and meeting each other in person. This project began in the North American ILAE region within the Global Health Task Force. The goal of the task force is to advance epilepsy education and care globally. And we really thought this repository would help meet some of those needs. The repository is being moved to the ILAE Global Advocacy Council webpage. Here are the goals of the database. We hope to improve the care of persons with epilepsy globally by increasing collaboration, reducing redundancy, directing resources, promoting advocacy, identifying volunteer or service opportunities, and targeting potential funding for future global health projects. We hope that the database will find many uses. I have listed some of the potential uses that the repository could potentially help facilitate. For example, if your team wants to undertake a demonstration project in epilepsy, you could find out on the repository where one has not been done. How about if you are from a university and your university or you want to work in a certain country? You could look in the repository to find out, is anyone else working there? And if someone else is working there already, do they want to collaborate with you? Or maybe you've proposed a project and you look in the database and find out that someone has actually already done that type of project there. What if you're a medical student, a resident, a postdoc, an EEG fellow, a nurse that wants to volunteer for a global health project? Hopefully you'd be able to find where someone could host you. How about if you're a funder that wants to fund a project, perhaps in a certain country, or target a certain population? Again, you'd be able to find that in the database. If you're a pharmaceutical or technical company that has resources that you want to donate, you'd be able to look through projects to see what would meet your goals or needs. Or if you live in a certain country and you want to advocate for epilepsy, you could look at the projects currently undergoing in your community to be able to use that in your presentations. The only way to make this work is if you all visit the website and add your projects so we can all see what everyone else around the globe is doing. I'm going to take you through the website so you can find it and hopefully start to use it. Currently, the best way to access it is to Google ILAE Global Health Database. The page you will land on looks like this. If you want to add a project, you simply click right there on the red button that says Add Your Project Here. I'm sorry, the red word, Add Your Project Here. The projects are all listed to the right, and currently there are 33, which is an easy number to look through quickly. But soon we hope it'll be too numerous to look through. So I want to show you how you can filter projects to be most helpful to you in whatever endeavor you're undertaking. So if you look in the bottom left where it has search entries, I'm going to go down to that page. The left column here lists the searchable items for the website. There are 7 filters that allow filtering of the projects: project status, ILAE region, language, patient age, project type, funding source, and project needs. I'm going to go through each of these searchable items individually to show you all of the potential filters. The filter for project status groups projects into ongoing, completed, or planned. Now the filter for ILA region groups projects, of course, into their geographical region. The language tab filters projects into the languages in which they are occurring in. They're listed here. The patient age filter allows you to look for pediatric, adult, elderly adult, or all age groups. The project type allows you to search for projects under the type to include clinical, community education, research, advocacy, stigma, mental health, capacity building, healthcare professional education, or other. The funding source tab denotes the funding source for the projects, so you can get ideas wherever other projects have found means to fund their project. And the project needs tabs allows projects to identify things they're looking for, so that if you or your group has these resources, you can sort through projects to find a match. Now again, the only way we can do that is if you all enter the projects you are working on into the repository, and that you use the repository to look and see what other people are doing. When you add a project, and again, you do this by hitting the red words that says add a project on the database page, you will be asked to provide as much of the following information as you can about your project. The title or the name of the project, and then a brief description of your project. The remainder of the questions that are asked help us be able to filter your project. These are the current members of the Global Health Task Force and the creators of the repository. We are all hopeful that you will visit the repository and the website and find it useful and look forward to working with you to advance epilepsy education and care globally. Thanks very much. Have a good rest of the meeting.
Great job, Karen. And is it ever exciting to see this Global Health Repository formally launched globally. So IBE can commit to putting a link also on our website under the global advocacy pages that'll direct people right to the repository. And I think our first addition to this will be the grant from the BAND Foundation and the great work you're doing, action in you and your colleagues are doing in Africa. So at this point, I invite all speakers of this session, so Alla and Joe and Gaby and Gardiner and the two Karens, to please put your camera on and go live. And what we'll do is we'll answer some questions that are in the Q&A box. Also, if anyone else wants to ask additional questions in that box, this is now the time. So I'll lead off action, but you please go one by one here. So we have a question. Is early and proper diagnostics of epilepsy mentioned in the IGAP? And that's probably best answered by Alla. Alla, is early and proper diagnostics of epilepsy mentioned in the IGAP?
Yeah, thank you very much. I started to write the reply to Natella Kujava, and hi Natella, very much pleased to meet you. Well, actually there are a lot of components related to diagnostics. And that's like, you know, throughout the action plan, addressing not only epilepsy, but all the neurological disorders. However, in the Objective 5, it's also mentioned. Out of my mind, I'm not sure what about early, but definitely appropriate diagnosis is mentioned several times. However, I would like to mention that the first draft is available on the WHO website. So just it's freely available. Please have a look. And it's very important, as Tarun mentioned, the formal period of consultation is finished. However, I'm sure that IBE will be able to submit additional comments to the WHO Secretariat. So please download and review this plan. You know, that's really very important.
So it sounds, thank you, Alla. So it sounds like this is still a very dynamic process and that our advocacy should not stop. So in September, we will get another draft of the plan and it'll be published. We'll put it on our IBE website and share it with our chapters. But most importantly, there is still time for feedback. If you feel that parts of the plan are not adequate, there's definitely time for feedback.
Mary, can I say another point? I think that's
yes.
also important. Well, currently there are ongoing consultations at the regional WHO regional meetings. And I know that IBE, especially Amos and Mary, contributed brilliantly to the regional event in Africa and a number of others. But this year's meetings are just starting. I think most of them will happen in September and October. And it's right time, as IBE is a non-state actor. Definitely it should be orchestrated by Francesca and the board. But it's a possibility to submit your recommendations only to the regional events. And also at some events, it's possible to make an intervention. It's possible because of the resolution and the ongoing discussion of the draft of the action plan, as all the ongoing major documents are being also discussed at the regional level. So please go ahead and contribute as much as possible. It's right time now. Thank you.
Thank you. We have a question that I think, Gaby, is best answered by you, and it's a question around availability of medicines. Do countries have mandatory systems of reporting drug shortages?
Thank you, Mary. I think a lot of countries don't have mandatory systems, and I think that's also a problem with a lot of essential medicines, that it's difficult to keep track of what is available, but also just estimating the needs, as I said in the presentation as well, to know what the needs are of the people, the health centers as well. So I think, yeah, I think a lot can still be done to improve these systems, to keep track of what is available in health facilities, but also at the central level. So what is available at the distribution centers. So we know when stockouts are happening and we can try to prevent these.
Eric, thank you very much. And Joe, we follow up on this question with you. It must be very difficult, and you come from one of the wealthiest countries in Africa. But what is this? How do we address this drug shortage? And what do you hear from your colleagues in Africa about access and how it impacts your ability to provide ongoing treatment and care?
I mean, I think it's an incredibly challenging situation. And in fact, as you said, South Africa is relatively equipped. And even in our setting, on a day-by-day basis, we hear about shortages and crisis. And in fact, our most recent one is that we ran out of intravenous phenobarbital, which is critical for us for managing children in status, and is basically a life-threatening situation. And there are multiple reasons for why that happens. But the challenges that I have, as you said, is often the tip of the iceberg to what affects my colleagues. And with the flipping of products and the running out at short notice and families not being able to access supply and then often not being given the correct formulations, it's just an incredible challenge that is just an ongoing battle.
Thank you for sharing that. And we have to start looking at as a global community on ways that we can monitor this and ways that we can change this. We have a question for you, Gardiner, and it is this. My question is for Gardiner. I'd like to learn more about Amos South Sudan collaboration. Is this still ongoing?
Thanks, Mary. Yes, they're still doing the work, and actually Action could, the IBE ended up partnering with AMREF, and Action went to visit the project to give really great feedback on what was working well, where there were opportunities for growth. So the projects are ongoing. I'm happy to share any more information, but Action, do you want to add anything specific about what you experienced there?
Yeah, sure. In South Sudan, I think the situation is quite bad when we talk about epilepsy, and I think it can qualify to be called the hotspot of epilepsy in Africa. We have households in South Sudan where not only one, two, but we came across a household where 7 people in one household have got epilepsy. And it's quite sad, especially in the 3 counties where AMREF is currently working. But AMREF has come up with a very good model of working, which is quite holistic. It starts from the demand side, it goes through the supply side, as well as police side. And it's working well in those counties where they are working in. And we hope in the future, as we continue working together, it's something that even other countries can emulate.
Thank you. Question for Karen Parko. So epilepsy has not received the attention of many key ministries around the world. So this is a tough one for you, but do you see the group working on the global registry as having a role in advocacy to see if we can improve our ability to work as a global epilepsy community to improve care?
Thank you, Mary. Absolutely. This is one of the main goals of this repository, is to be able to highlight projects, and not only so that you can advocate for them, but so that you can use the projects that are there to get ideas about how to successfully advocate.
Fantastic, thank you. And Karen Robinson, we have a question from someone who's asking, is there a plan to use the toolkit in other parts of the world? And that might be a tough one for you to answer, but we can answer it after you do, okay?
Okay. No, thank you. I've responded also in the Q&A saying that basically Epilepsy South Africa, we were chosen to facilitate the advocacy toolkit with the African chapters, and I think the best, and it is a very important question because it's so needed that it needs to be done, you know, with other countries. So Action or Mary or Anne, I think you guys would be the best to basically just give information about that, the rolling out with other countries.
Thank you. And I know that Gardiner linked us with a donor because there was a request from Africa to translate the toolkit into Portuguese and to French for use continentally. And also there's been conversations with the Latin American region to translate the toolkit into Spanish, but beyond translating it, regionalize it so that the examples that are currently in the toolkit for Africa would be examples for Latin America. The toolkit is available on the African IBE website, and I hope it's also available, Anne can correct me, but I think it's also available on the IBE website. So you can access this toolkit, download it, and please use the tools in it. They're user-friendly, as Karen mentioned, but most importantly, the whole project was designed to increase our capacity to feel comfortable advocating. Some people it comes naturally, others need more tools, and that's fine. It's to have a plan of action. So Karen Robinson, did you find that when you trained, you saw a change in the participants, like a eureka moment that they said, I can do this?
Yes, definitely. And I think also with the group of people that we trained, it was people from different levels also. It was from a volunteer to someone who's sitting in a director's position. So it was quite challenging for us also as facilitators to kind of take the toolkit and adapt it, you know, so that everyone can understand it. My thing, with the question that you asked, what I've experienced it is people come with different experience, like a volunteer will come, or people that just started, they haven't actually have no advocacy campaign or new organizations that was formed. So there was, I think, every day that we were busy facilitating, you get the responses from the AHA, and even the assignments that we had to kind of see. And what I liked about how we were doing the training and testing the tools is that based from the assignments that was given to the participants, and they did work mostly in groups, is basically taking taking them through the whole process. And at the end of the training, they actually have a plan that they need to be, that they are, or they must implement. And then obviously it needs to be monitored. So definitely I would say that we could see that people learned from people not knowing anything about what advocacy is, to people that maybe have experiences working and developing tools, but they also, and it was a nice platform where, same like this platform, where we could share what's going on in our country and also what is working in your country. So a lot of partnership and collaboration also happened between the sessions and learning from one another.
Thank you. Gaby, we've been asked by a couple of people, what can we do in our own countries to improve access to these important drugs for people with epilepsy?
Yeah, I think that's a complex question. So what we actually do in a lot of our other projects is we set up multi-stakeholder engagement platforms where we bring together the public sector, the private sector, but also civil society, so NGOs and community-based organizations, where we share evidence on the state of access for the specific commodities, where these different stakeholder groups work together to try to come up with solutions to improve access. And this has actually been quite successful, for example, for our project on sexual and reproductive health, where we do research on, for example, the availability and affordability of sexual and reproductive health commodities. And we share this with Ministry of Health, but also, for example, the central medical stores or the similar entities like that in different countries, to say, okay, well, we found that the availability is very low, or we found that affordability in the private sector is not, that the commodities are not affordable for a lot of people in the private sector. And we've actually heard from them, for example, the Ministry of Health, that this really helps them because it provides them with evidence of what the actual situation is in, for example, rural facilities. So I think working together with all the different stakeholders who are involved in improving access to, for example, epilepsy care might help. I think it has also been raised by some of the other panelists, as well as what I've seen in the Q&A questions talking about advocacy. So yeah, I think that's one thing that could be done, trying to really work together with all the different stakeholders to improve it, and listening to each other and not trying to point fingers at each other, but trying to come up together with the solution. Thank you.
Thank you, Gaby, for that response. And yeah, we're looking forward to continue working with you and learning more around issues to do with drugs. As we draw to the close of our discussion, maybe to all our panelists, I would like to give you each maybe 1 minute each, just to talk about where do we see epilepsy in the next 10 years, or where do you want to see epilepsy in the next 10 years, looking at the Intersectoral Global Action Plan that is currently being drawn and it's on the table. So I'll start with Joe, and yeah, Joe, maybe Professor Joe, you can go first.
Thanks, Amos, and thank you to Mary and yourselves as well for putting this fantastic session together. I think really, as I emphasized in the talk, children are our beginning. Without looking after our child health, then we're going to be in a bad way as things move forward. And epilepsy is such a good stepping stone for illustrating good comprehensive healthcare. I would like us to implement that approaches to healthcare are embedded across from a specialist through to a community level, that nobody feels disempowered about how to access good healthcare, and that we focus on prevention, early diagnosis, and good interventions that we're giving, good support, targeting stigma,
really taking stigma away as much as we can, and educating across all levels. And one of the areas that the ICNA has been focusing on has been really trying to promote education for people that are truly working, clinicians working at the rock face, to get it right from the beginning, from when a child first presents with a neurological condition that is often epilepsy. Thank you.
Thank you so much. Let me move to Dr. Karen, University of California. Karen Paco.
Thank you. I would love for the intersectoral plan to make epilepsy a dinner conversation around the world. I want to bring it to the forefront. I want people to know what it is and what can be done with it. And most importantly, especially in this digital world, it's time to all work together.
So much. And Gaby?
Thank you so much. So to be very short, I think what I would like to see is some barriers to accessing, for example, phenobarbital being removed for people in low and middle income countries. So making it easier for them to access them, have healthcare workers having less barriers in prescribing them, less of all the extra regulations because of its control status.
Thank you so much. And let's move on to the social worker, Karen.
Thank you. I think for me, I would also say, early intervention and prevention. There's still a lot of, my other colleagues, they say there's a lot of stigma going around for epilepsy. So epilepsy we need to speak out. So for me, education, definitely also a multidisciplinary team, like there is, in Africa also, we don't have a lot of specialists. We're blessed to have, like Dr. Joe is here, Professor Joe is here, and other specialists that we work closely with. And I think also advocacy, we have this toolkit, it's available, and we need for people with epilepsy also to self-represent, to speak up for themselves, and we can only do that by, I think a lot of the speakers spoke about advocacy was on everyone's, I think, presentation. So for me, that needs to come out stronger and louder, and we really need people with epilepsy and other disabilities to represent themselves. And I think also with training, there's a lot of training still needed for doctors, for nurses, even for social workers or psychologists within the field of epilepsy and other disabilities. So that goes again to education. And I want to say lastly, we are at a virtual world where everything is happening, and COVID has pushed us more into that. And just from our side, within our organization, we had to also think out of the box and think of reaching people within rural and urban areas by using WhatsApp, by using Zoom trainings. And that is what we should do, by using radio, the radios, to get our word out of there. So yeah, so that's all that I want to say. There's a lot more, but yeah, I'm going to stop there.
No, thank you so much. And we move on to Gardiner. Where do you want?
I'll be super quick. Two things I'm thinking of is building on the education idea, educating donors, governmental and private and individual. I think we really need to tell this story and engage more people, because the opportunities are so huge and feasible to make a difference in this space. And then the other idea is working to continue to integrate epilepsy care into the traditional primary care and public care approaches globally. I think there are a lot more traditional health groups that could engage in this issue and just don't know about it or know about the evidence-based interventions available. Thank you.
Thank you. And lastly, Alla.
Thank you very much. I would like to thank for the invitation and congratulate with the success of all this excellent session. And wow, I enjoyed very much all the talks. I think their best probably conclusion and wish could be to make epilepsy a public health imperative. as we all stated in the global report. And also with so many documents on epilepsy that we have in collaboration with the WHO, that's unique. 2 resolutions, the global report, the decision that makes us the best candidate for the entry point to all the other neurological disorders. So I would like to finish with that. And also all these documents and also the action plan would constitute their very powerful instrument that will help all our member states and all the communities and all the people, all the healthcare providers to reach their governments. So we need to use them, and then we will reach our goals. And I would congratulate everyone for the excellent collaboration. It's a pleasure. Thank you.
Thank you so much. And over to you, Mary, as we close, and thank you.
We're on to the next IBE session. Thank you, all presenters. It was a great session, and enjoy the rest of the program.